Okay, make a start. Welcome to the second webinar in a series of Health Innovation Network Innovation Insights. And we're going to describe the program of AI brain imaging for thrombectomy that we supported in partnership with NHS England and one of the main company supplying stroke AI to the NHS, Brainomix. We've got great array of speakers. We will leave hopefully 20 minutes at least for discussion and questions at the end. So next slide, please. For those who don't know me, I am a stroke physician in the Thames Valley and Chief Executive of the Health Innovation Oxford and Thames Valley network. So I'm just going to describe for those people who won't know the details of stroke, what the problem was and the need we were addressing. And then we've got a series of speakers who are very grateful for coming along and speaking today. And I think the range of speakers illustrates the this program was successful because of the involvement of strong leadership and partners in NHS England, particularly within the National Stroke Team, with industry, which George is representing, local clinical leadership in the Thames Valley, and then our team's evaluation with Tracy. Next slide. So, as usual, put your questions in the chat, not the Q&A channel, and then I'll pick those up at the end. We will post in links to the chat at relevant points, and please give us your feedback at the end, as usual, to help us improve future ones. Next slide. So our objectives here was to give an understanding how an AI innovation was successfully and rapidly scaled up nationally, and this remains a unique example of an AI solution which is in every NHS organisation that could benefit from it, and meeting a clear need and having a clear impact. We want to share with this audience the key elements that drove that successful implementation, and these will be familiar to many: the importance of collaboration, the importance of leadership, both clinically and from senior NHS managers, the alignment with national policy, and the importance of effective local clinical networks. And it also provides a toolkit that can be applied to digital transformation and other pathways. Next slide. So this is just for the benefit of people joining this webinar who are not from HINS. The rest of you can switch off for the next few seconds. So there are 15 health innovation networks. We were the Academic Health Science Networks. We've been running now for 11 years. We were renamed, I think, giving us a better name from Academic Health Science Networks, because we're not really academic, now called Health Innovation Networks, and we're currently in our third license, which runs until 2028. And we're commissioned both by NHS England, that will be the combined entity with DHSC in the future, and the Office for Life Sciences. The commission from Life Sciences is to support industry develop products of value for the NHS and help them obtain further investment and growth, thereby contributing to economic growth in the UK. Next slide. So we see ourselves as experts in health innovation adoption, not in invention or creation. That's for the research and life science commercial sector. So we look to match solutions to the needs of the NHS, and then importantly, help the implementation of new solutions at scale. The brief summary at the bottom I won't read through of the impact we have had in broad terms. And for our OLS commission, we have a set of metrics which look at what return on investment the economy gets for our commission, which is 30 million a year, using a standard methodology called the Treasury Green Book methodology. We have a very high return on investment, much greater than you would see for a typical government-led program. Next slide. So we work at that intersection, often called the triple helix, between the health system, life science industry and academia. And I think you will see that how that was critical for the spread of the stroke AI. And we find solutions of promise. We test some of those with real world evaluations, and then we implement. And the combination of having local networks with an engagement of partners which you can achieve locally across a 3 to 5 million population, and then work as a national network, gives us the ability to both act locally but impact nationally. Next slide, please. So briefly onto the problem. Next slide. So back in 2017, after major trials were published showing that thrombectomy, a procedure which removes a clot for those people who have a stroke due to a large clot visible in a blood vessel, that the 10% of patients coming into hospital with stroke were eligible. That's of all stroke patients, some 90,000 a year in England, but only 1 in 10 was getting it. But over the next 7 years, we were able to introduce AI brain imaging. There's 3 different products, of which Brainomix is the dominant provider, to all 107 stroke units in England, which I think is a real achievement given how long it takes normally to get over 95% uptake, let alone 100% uptake of a new way of working. And as a result of that, we've substantially increased the number of people receiving thrombectomy. You'll see those data, and at least 1,000 people avoid long-term disability every year. So this is a very big impact. Next slide. A bit more details. About a third of people with acute stroke have a stroke due to a blocked artery with the occlusion of a large vessel, and we define that as a clot visible in the larger arteries in the brain, at the what's called typically the middle cerebral artery, and also at the back there's the basilar artery. And this type of stroke has a very poor outcome. So even with IV thrombolysis, the standard of care for acute treatment before thrombectomy arrived, 75% of people are dead or disabled. Thrombectomy is one of the most powerful treatments in medical practice. It increases that good outcome from 25% to nearly 50%. This is far more effective, for example, than a primary coronary intervention for acute coronary syndrome, which obviously as an approach, this mirrors but follows in its wake. So the first thing is, if you're going to introduce a treatment, you have to know what the eligible population is. So with the research group I'd set up many years ago in Newcastle and colleagues in Exeter, we did modelling work on the SNAP database and established that was around 10,000 people were eligible. So that's important to know. The other major challenge is that unlike intravenous thrombolysis, which have been given in any acute hospital receiving acute stroke patients if they set up properly, thrombectomy is a complex procedure requiring an interventional neuroradiologist, an anaesthetist, and intervention suite, and that's only available in comprehensive stroke centres, which for the most part are in neuroscience centres. But most patients present to these other 75, it's actually a bit more than that, 83 centres called primary stroke centres, which can't deliver it. So you have to transfer people rapidly from these primary stroke centres to the comprehensive stroke centres when they present there for thrombectomy. And this is a very time critical treatment. So each minute's delay impacts on your likelihood of a good outcome. The other thing we did working with David, who you'll hear from later, was with the National Stroke Team, was in 2019, we produced some practical implementation guidance, which we subsequently updated on how do you set up a stroke thrombectomy service and the network for transformation. So we did some background work to understand the problem and the issue before we actually ran the implementation program. And the main treatment that is used in thrombectomy is something called a stent retriever, which is illustrated on the side, which is passed through typically the artery in the leg up to an artery in the brain. It expands this wire mesh and pulls out the clot, which you can see on the bottom picture. Next slide. I think that just shows the typical biplanar suite. This shows that the impact in figures of who benefits. As you can see, about half of people get some benefit, and in half of those quarter, you avoid disability that would otherwise have been present. And the somewhat more complicated slide on the right shows the scale we use, which looks at the ranking benefits, and this goes from, if we look at 0 to 1, this is people who have a very good recovery from it. The treatment difference, if you treat really early, is around 20%, and that declines over time. So from 120 minutes, 2 hours, to when you get to about 6 hours, you've lost benefit. So we have to get people as soon as possible for intervention. Next slide. Other work we did was it needed to be commissioned, and it wasn't commissioned in 2017. We worked to highlight that and were able to get onto national media, which I think was an important influence in getting everything to agree to formally commission thrombectomy as a specialised commission procedure. And the other problem I've talked related to the primary stroke centre issue is that neuroradiologists are rarely present in primary stroke centres, and out of hours, there's often no reporting radiologist present in the hospital, but you have contract out of hour reporting systems, which are not necessarily very rapid, and they're also not very high quality sometimes, I'm sorry to say. And the other challenge is you can move images around from one hospital to another, which is necessary for the interventionists to look at that before they transfer the patient, but it's very slow. So one of the things we look at, and you'll hear about later, is the efficiency of the system is something called the door in, door out time. How long when somebody presents at the front door of a primary stroke centre is it before they get out and arrive at the comprehensive stroke centre? And this is often over 2 hours, and this is true in many healthcare systems. So the two major developments you're going to hear about are the technology that developed the detection of LVO stroke, but also what really added value was linking that to image transfer across the network more rapidly using the cloud. And I think that this was equally as important as the diagnostic itself. And the slide on the left shows you how the Brainomix system works, where it highlights with that red ring where there's an occlusion. Next slide. So over to you, Darrien.
Thanks, Gary. So I'm Darrien Bold. I work at NHS England, which some of you will have heard recently is apparently the largest quango in the world. I'm currently working in elective recovery, but recently spent a couple of very productive years leading the National Stroke Programme, where I work with colleagues across the country on rolling out AI decision support software nationally. So I'm going to spend a few minutes talking about how national leadership across a specific clinical area can have an enormous impact more locally with improved pathways and outcomes. So starting 5-6 years ago now, January 2019, an NHS long-term plan was published, which set out a wide-ranging set of programmes and recommendations around upgrading technology and using digitally enabled care across the NHS. So you'll see here, if you can read clearly, that among the milestones for stroke is recommending the use of AI to support clinical decisions. And as Gary mentioned, at the time of its publication, only 5% of stroke units were routinely using this software. So at this point, we've got a very strong policy steer around using AI to increase access to time-dependent treatment, which was part of a much wider arsenal, if you like, of policy and guidance documentation from Department of Health, the likes of GIRFT, which made very clear what a good stroke service should provide. Fast forward, though, a year to early 2020, and the coronavirus pandemic has placed unprecedented pressure on frontline services. So our national stroke leads recommended we increased the pace in trying to adopt AI software across hospital and regional services so patients can access timely diagnosis wherever they present. So NHS England, we provided national leadership on this rollout through quality program digital teams, and what that did is it provided more consistency and accuracy and eliminated some duplication. So for instance, we crafted a nationally approved set of information governance templates which trusts could then adopt and tailor to their own local requirements. We led on the creation of a standalone AI stroke procurement framework, which was the first of its kind in diagnostic circles, which brought together expert contributions from policymakers, clinical leads, the Oxford and Thames Valley Health Innovation Network, amongst others. And that sort of thing is a good example because it offered a simple and compliant course for purchasing the software, and therefore did a lot of the heavy lifting on behalf of stroke units who could then work together under the new delivery model for stroke put forward by NHS England, which you'll see in a minute. Next slide. Which came about through the 2021 National Stroke Service Model, where our integrated stroke delivery networks, ISDNs, were established as formal entities. And since then, we've seen them nationally as very much the key vehicle for delivery of some of those key improvements in the stroke care pathway, which you can see in the square box there, which are all designed to ensure a more patient-centered, evidence-based approach to delivering improvement and change. Next slide, please. And that is fundamentally what has driven the successful rollout of AI, which, as you see here, in terms of pathway optimization, was regarded as one of the 5 pillars for improving access to thrombectomy. So at the height of the pandemic, slippage against those expected activity levels for thrombectomy were escalated to senior NHS England leaders. And this group, the TIG, Thrombectomy Implementation Group, was set up, and it's done a lot. So for instance, money is always a key factor. We sent out over £2 million of pump priming funding to neuroscience centres to get things moving with some of this. Since then, there's been an annual settlement for renewing AI licenses, along with other funding streams for increasing access to thrombectomy. And at a very early stage, NHS England identified that to capitalise on any momentum of this work, it was essential to have a senior manager overseeing it from a national perspective. So there was dedicated expertise and leadership in things like governance, safety, procurement, contracts, things I've mentioned before, relationships with industry such as Brainomix and other partners. And that was the role I stepped into. Next slide, please. So I've seen, and we've seen, a range of lessons learned in that time, which I won't go into. We've touched on most of them in the past few minutes, and hopefully they give you a flavour of where that national fulcrum or repository of expertise, if you like, can help to unblock issues and drive progress at a more local level. And I'll leave you with one thought. Professor Sir Mike Richards wrote in his 2020 review of diagnostic services that AI would be of significant benefit to stroke treatment amongst other pathways, but 3 things are required: national guidance, funding and implementation support. And we were able to provide all 3 of these, and with each one in place, coverage rose from that 5% in January 2019 to 100% by May of last year, which is the largest scale adoption of AI in secondary care. So with that, next slide, I'll hand over to Dr. George Harston.
Thank you, Darrien. Thank you, everyone. My name's George Harston. I'm Chief Medical and Innovation Officer at Brainomix, and also a stroke physician in Oxford. And I'm going to tell you a bit about what we do as a company in order to improve patient care with stroke. So the first thing to think about is how do you add value to a patient pathway? Now, this is absolutely essential. A lot of AI technologies, I think, fall foul that they don't seek to add value to a patient pathway, because that's what we're trying to do in healthcare. It seems self-evident, but actually a lot of solutions don't necessarily address a problem or provide value. And broadly speaking, with imaging, which is particularly in the sort of diagnostic setting, so a presentation, there's different ways that you can use imaging to drive treatment. And you can identify more patients for treatment, you can identify the right patients for treatment, or you can treat patients more efficiently or faster. And all of those are a way of adding value to a patient pathway. And I put a picture up here of Sir Godfrey Hounsfield, who invented the CT scanner. And one of his, his amazing innovation was widespread across the NHS at the time of his death. But one of his great regrets is that his innovation never actually helped him in terms of adding value. He died of a fibrosing lung disease, but that's something else that we're working on now. Next slide, please. And so you've got to add value, and stroke is a great condition where you can add a lot of value because there's a big unmet need. So that's the next theme that's really important. What's the unmet need? What problem are we trying to address? And in stroke, broadly speaking, I think of this in two ways. One is time. The adage in stroke is that time is brain. Every minute that goes by before the treatment is delayed, patients have a worse outcome. More of their brain dies, and they're less likely to get home and be able to do the things they could do before their stroke. But not only that, that's bad enough, but actually a huge proportion of patients, if you heard from Gary earlier, are missing out on treatment. And that's ubiquitous around the world. The problem bigger in different economies, but actually in most, in fact, in all countries, there is a significant under-treatment of stroke patients. And so we're ending up with patients having less good quality of lives in the longer term, which, obviously is a burden on the patient, but also burden on the wider economy as well. Next slide, please. So when we trying to understand how to build a technology to try and address an unmet need, you have to start with that unmet need. And this is a schematic of the way you might develop a product in for clinical care. So you have to really crystallize out what your unmet need is, and then that defines everything else that follows. It defines the type of data you need, the way that you develop your product, and it is a product. It's not an algorithm. Algorithms are what are core to what we do, and you can get very interested in algorithms. But actually, an algorithm on its own doesn't really help very much. It has to sit in a product that's embedded in a patient pathway. And then you need to validate your technology and demonstrate not only its performance, but also its value before you get clinical adoption. And then you need to monitor it once it's in the wild, once it's being used to improve patient care. And if you just click on a couple more clicks, we can see that the generation of evidence, the validation of performance and demonstration of value feedback. So there's a life cycle of a product, so that you need to continue to innovate and develop your technology to maximize the value add to these clinical pathways. Next slide, please. So a bit more about then the unmet need in stroke and how we shaped our technology in this instance to really try and add the maximum value to the healthcare system. Now you'll hear from others on the call about how we've partnered with them to extract the biggest value, because clearly you need to use a technology to add the value. But for us, when we design the product, we think about where's the biggest problem. And as you heard from Gary, most stroke patients don't go first off to a specialist stroke centre. They'll go to their local hospital, which will be a very good hospital, but the access to specialist expertise can be more limited. And that can be both in terms of personnel, so for example, specialist radiologists who look at brain scans in real time, and it might also be the hardware, the imaging technology that's available. And so you need to design your solution around the routine imaging that's readily available in every hospital in a network. And for stroke, that's a non-contrast CT scan and increasingly a CT angiogram scan. So the technology needs to address that. And it needs to think about what's the problem that the current doctors and nurses, clinicians who are dealing with the patients need to be solved. So about identifying patients, about selecting the right patients and improving communication. And so for us, that means that we really double down on the algorithms within the product that focus on those so-called simple images, the non-contrast CT scan, so that we can add value as best possible, and also make sure that it's implemented network-wide, so that we don't just help those patients who go to a specialist centre. Let's say 20% commonly might go to the specialist centre, but the 80% of patients who have the biggest unmet need who go to the surrounding hospitals. And then you have to demonstrate the value and actually show, in order to get adoption, that you can make a difference and improve the way that patients are being treated and therefore their outcomes. Next slide, please. And in order to do that, we have a range of algorithms and products within the sort of the wrapper of our technology. So we have technology that looks at non-contrast CT. We look for key clinically important features. You know, is there a vessel occlusion? Is there any blood? Is there any extensive injury to the brain already? Is there a blocked blood vessel? How good is the blood supply to the brain? All of these different features that can then feed into the decision making by the clinician, either to prompt them or alert them that there's a patient who's had a stroke and needs treatment, or to inform the decision making, give them more confidence about the diagnosis and appropriate management. But that's not enough, of course. You have to then embed it in your clinical pathway. And in a hospital, at an individual hospital, it means that the outputs need to be readily available wherever the clinicians are looking for them. So not only do we send our results to the hospital imaging system, but they also sync to a cloud, which enables you to be able to look at the images on your phone. So, you know, if you're in a corridor in the hospital or on call at home, you get an alert, and within about a minute or two of the scan being done, you can see the images. And really importantly, you then have to connect the network. So when I'm on call in Oxford, I can see the scans in real time for the patients in the hospitals that refer to us, at Reading or Swindon or Milton Keynes, etc. And so that product side of things, embedding in the patient pathway, is absolutely critical to extract the value from the algorithms. Next slide, please. So this is what it looks like in practice. This is the sort of typical, if there's such a thing, stroke pathway of a patient with a suspected stroke turns up in A&E at their local hospital. They get a CT scan, a CT angiogram, and then these different technologies will provide information to the clinician, alerts about their whether or not they've had a stroke, alerts about what treatments might be appropriate, and then an ability to communicate that with a central specialist comprehensive centre, thrombectomy enabled centre, to guide the selection of those patients who need that time critical transfer from the primary stroke centre to the specialist centre in order to get specialist intervention. And that might be guided by further imaging, such as specialist imaging, CT perfusion, but actually increasingly with the use of AI, your routine non-contrast CT angiogram is more than enough for the vast majority of patients to make a decision. So in summary, you need to demonstrate you can add value to stroke patients in order to drive adoption. You need to embed it in your clinical pathway, and most importantly, you need to directly address the biggest unmet need facing patients. And with that, I'll hand over to Kiruba.
Thank you, George. Thanks. I'm Kiruba Nagaratnam. I'm a stroke physician at Royal Berkshire Hospital in Reading, and also the clinical lead for the local integrated stroke delivery network. So in the next 5 minutes, going to talk about the power of networks. So this is the situation in Thames Valley before 2020. The 5 acute stroke centres that are referring patients to Oxford and the Oxford University Hospital in the region, all of them existed and worked in a silo, and there wasn't a proper network that enabled these hospitals to work together, or a local leadership to bring those hospitals together. And we've heard about the mechanical thrombectomy. So at that point, only about 1 or 2% of the patients in the regions were receiving mechanical thrombectomy. This is the situation pre-2020. And also this is pre-establishment of the integrated stroke delivery network. And in this sort of scenario, Oxford Academic Health Science Network, which is the predecessor of Health Innovation Oxford and Thames Valley, brought all these hospitals together and provided a joint local clinical leadership to establish a network, and we call that network Titan. That means Thrombectomy Innovation and Transformation Network. And the single vision of this network, and this is a shared vision between all these hospitals, is to develop an effective and efficient thrombectomy service that would enable more patients in our regions to have mechanical thrombectomy. Next slide, please. So the core values of our network is collaboration and implementing innovation and share the learning. As you know about the diffusion of innovation is that there should be early adopters, and they should be able to share their experience with everybody else so that the adoption can spread. And what our mission was, first, as I said, to provide a leadership for the existing pathway, And the most important one where Health Innovation Network played a key role is implementation and evaluation and innovation. In this case, it's artificial intelligence software to identify appropriate patient for mechanical thrombectomy, which you've heard a lot about from the previous speakers. In addition to that, our other missions were to provide a governance framework and a quality assurance that the mechanical thrombectomy service is functioning in an effective manner. Next slide, please. So what have we achieved? The first thing that we did was to review the whole thrombectomy pathway end to end. That means from the patient's referral from the ambulance services to primary stroke centers, identification of the scans, referral of patients to the comprehensive stroke centers, all the way to repatriation back to the referring centers. And after reviewing this pathway, we agreed amongst ourselves a protocol how it should be done. And the protocol had the integral element, which is the implementation of artificial intelligence software, which is Brainomix for our region. So as part of it, as you've heard from Gary and George, that we have deployed Brainomix AI in the comprehensive stroke centers as well as all the referring centers, and the AI image was able to be shared through a cloud network between the hospitals in real time. As you can see, as a result of it, what happened in our region with regards to the number of patients who received mechanical thrombectomy. That has risen from 34 patients in 2019-2020 to 230 patients in the last year. So you can see the exponential increase that corresponds to us becoming the first AI-enabled network in the country in the mid of 2020. So this shows how we come together as a network, and sharing our experience implementing AI had a direct impact on the increasing number of mechanical thrombectomy in the region. Next slide, please. The next is diffusion of innovation. The Titan network was the early adopter, and we had the experience of working together with our front door colleagues to implement this software across the pathway. And Brainomix partnered with us and Health Innovation Network and successfully applied and won the AI Health and Care Award. That played a key role in terms of scaling up this technology. And then come into play the other stroke networks. At this point, integrated stroke delivery networks were established, and they were enabled to provide local leadership as well as the engagement, which is absolutely key, the engagement from the front door clinicians, stroke physicians, and the radiologists and the managers is absolutely key in terms of scaling up this technology across vast regions through these networks. And therefore, ISDNs played a key role, and Health Innovation Network, as part of this award, supported this implementation. As well as this, Brainomix supported the networks and the clinicians in terms of providing this, in terms of expanding the technology. One last thing is, when we have the technology, when we implement it, evaluation is important. And Health Innovation Network, Oxford and Thames Valley undertook this evaluation. And Tracy will talk about it. This is the largest evaluation that we've undertaken, enrolling more than 80,000 patients across 5 stroke networks involving 26 hospitals. So we were able to do all of it through collaborating as a strong network. Next slide, please. And my last slide is, so what's the success? So there are 3 key things I cannot emphasize more. First, as you've heard from my previous speakers, is about clearly identifying a problem and to find the right solution for the problem, right AI solution. So that's number 1, the right technology. The second one is the right system. So in our case, it's a national policy, as you've heard from Darrien. So the NHS long-term plan clearly focused on increasing the number of thrombectomies undertaken in the country, which was supported by the National Stroke Service model, which advocated for the integrated stroke delivery networks. They played a key role, as well as the National Optimal Stroke Imaging Pathway, which clearly identified where artificial intelligence can be incorporated in the imaging pathway. The third is pivotal. This is the part of network. That means the local and national leadership through the networks, and the networks that provided the engagement, which is absolutely pivotal in terms of implementing and scaling up the artificial intelligence technology. Thank you very much. So I can hand it over to Tracy.
Hi everyone, thanks Kiruba. Hi everyone, I'm Tracy Marriott and I'm the Director of Clinical Innovation Adoption and was the programme lead for this evaluation that I'm going to give you a very high level overview of today. So this work has given us some really important evidence around how AI can really make a difference in stroke care, particularly in reducing door in, door out times, which Gary referred to earlier, and ultimately for improving patient outcomes. The slide that you're seeing now, I'm just going to talk to that. The AI award was set up, Kiruba mentioned it in his slide, to assess AI technologies and create evidence and speed up the adoption of these AI technologies. And it focused on promising technologies that could potentially enhance clinical decision making and efficiency. And it certainly did a good job, I think, with some of the key critical success factors, which I refer to on the right side of this, such as understanding and categorizing the complexity of these AI technologies and innovations. And importantly, it also provided pump priming funding to support early adoption. As a HIN, we were pretty well placed to deliver the programme, thanks to our background, which you've heard already, around adoption and evaluation work and our involvement with the stroke transformation work that in MT in our area. Plus, we also had great connections with the ISDNs and the national girth leads, and you'll hear from David a bit more about that later. And also, we've been working with Brainomix for quite a while, and that certainly helped. Our evaluation started during the pandemic, so challenging time. It went from March 2020 to March 2024, and we worked with 24 participating sites and 5 ISDNs across England. And we really focused on the key things that you can see there on the left side, which were around safety, accuracy, effectiveness, value, etc. And when we did this work, Brainomix was ready for deployment, though it hadn't yet been widely adopted in the UK. Next slide, please. So to understand the impact of Brainomix, we used a mixed methods approach. No one would be particularly surprised about that. Combining health economic analyses with the structured evaluation, at baseline, midpoint, and at the end of the programme. On the quantitative side, we used data from the Stroke Sentinel National Audit Programme, which is actually really helpful. And we also used HES data, we used technology usage reports, and we also compared mechanical thrombectomy rates across different sites. The qualitative side, we carried out interviews, workshops, and focus groups with stroke clinicians, and did pathway mapping to pinpoint integration challenges. And bringing this all together helped us to see, for us to see how Brainomix was influencing operational delivery in the real world. And it gave us some really good insights into clinical outcomes and helped us to support change on a wider scale. Next slide, please. One of the most outstanding findings was how well hospitals using Brainomix performed. We saw consistently higher mechanical thrombectomy rates compared to sites not using the AI tool. And as you can see, John Radcliffe and I don't know, click on please. John Radcliffe and UCL also did very well with their performance, 12% and 8% at the time, way above average. And it really showed the power of AI to help clinicians identify more patients who are eligible and ultimately improve the outcomes on a national scale. Next slide, please. So in terms of the qualitative side, we spent time listening and surveying 36 stroke specialists to get their views, and the chart shows a comparison of baseline and midpoint responses, where 78% agreed that AI helped them identify patients who were eligible for MT. They highlighted the speed, consistency, and extra decision support that AI brought to the practice. But one key takeaway that I would say would be that adoption doesn't happen overnight. You know, of course, we went by the general principle of, you know, when people adopted, how give them 3 to 6 months to bed in, but you also need to support them. And certainly success does depend on good workflow integration, clinical awareness and training, and building trust in the technology. Next slide, please. One of the most powerful findings from our evaluation was the dramatic reduction in door-out time that you heard Gary refer to. With AI, the median was 128 minutes. Without it, it was 192. And that's a time saving of 64 minutes with a p-value of less than 0.001. It's certainly statistically significant. And as we all know, every minute counts in stroke care. Faster transfer means better chance of recovery and reduced disability. The multivariate regression analysis confirmed that AI was a key factor in reducing transfer times, and in fact, just making transfers faster, it doubled the likelihood of mechanical thrombectomy happening at all. So just to sum up very quickly, stroke care supported by AI did lead to faster transfers and higher thrombectomy rates. Clinicians saw the value in AI, but of course they need support and time to, you know, get to grips with things. And most importantly, AI-driven improvements are helping to reshape stroke pathways, delivering faster and better care for patients. Thank you very much. And I'll pass you on to Dr. David Hargroves.
Great, thanks so much, Tracy. And I'm conscious of time. I'll say hello to everybody. I'm David Hargroves, a stroke physician from South East Coast and the National Clinical Director for Stroke. So I've had great privilege to be working with colleagues on this call over probably the last 8 years. First as the GIRFT clinical lead, and the GIRFT project, getting it right first time, started in 2012 with orthopedics and moved into stroke in 2017. And with my colleague Deb Lowe, we visited all the acute stroke centres in the country, and there were many things that we found that you can read at your leisure in the 230 pages for the GIRFT report, which is on the link below. But one of the key factors was collaboration, relationships and leadership as part of the stroke pathway. Access to imaging was the other thing that we found was very, very poor. And we've heard those statistics of only 1 in 20 patients having any access to AI, but there was a problem in delay in getting the right scans quickly enough. Next slide, please. And as a result of the GIRFT work starting in 2017, we developed this National Optimal Stroke Imaging Pathway, which hoped in a pragmatic form to ensure that patients got the right scan first time round and quickly. And we were aware at the time in 2017 of the evidence base for AI. And that is why we included within the NOCIP this option to be using AI both at the CT, CTA and the CTP stage, because we thought this would improve the speed and the volume of patients selected for recanalization therapy. Next slide, please. Now, getting AI used is not always straightforward. I would say to colleagues, if you have a tool that you think can help solve a solution in a pathway, you must involve all of those other organizations that play a part. Now, NICE is one of those. And in 2021, there was serious concern raised by NICE about the efficacy of AI. But by working with them, and by that I mean the Getting It Right First Time program and the National Stroke program, we were able to bring in some of the real world data that Tracy and colleagues were collecting and demonstrate to NICE that in fact the sensitivity and specificity of AI was only one of the factors that might make it of value to the NHS. And so, of course, you'll be delighted to hear, next slide, please, that by January of last year, we were able to demonstrate to NICE that this had real value in the NHS. And of course, they concluded that it should be used as part of routine clinical practice within the NHS, as long as it was used within the confines of the licence. Next slide, please. So how does this actually equate into actually patients getting more scans that are appropriate for access to both perfusion therapy, TPA, and also mechanical thrombectomy? Well, we worked with another organisation within the NHS, Right Care, to undertake an audit looking at whether or not patients were getting access to, and we've got a graph here of CTAs. And remember, thrombectomy, you must have an angiogram of those neck vessels and intracranial vessels. And you can see from the solid green bar chart that over the years, more and more patients are getting access to AI decision support tools for CTA. And we have no doubt that this correlates with more patients getting thrombectomy and more patients getting it quicker. Remember, every 20-minute delay in access to thrombectomy reduces your chances of a good outcome by 1%. So I'll stop there. Thanks, Gary.
Thanks, David, and thanks everybody for that excellent overview. We've got just under 15 minutes left for questions and discussion. I'll start. We've got one question in the chat, well, two questions. So it is, does the ISDN cover thrombectomy on calls? So the thrombectomy on call system is done on call is done entirely by the Comprehensive Stroke Centre. So in Oxford, that's a team of stroke consultants, including George, and it used to include me. I now work in one of the spoke hospitals at Reading, and then also a rota for interventional neuroradiologists and anaesthesia and radiographers. So quite a lot of people needed, and they typically are all in the Comprehensive Stroke Centre. The ISDN isn't directly responsible for that, but the ISDN was quite involved in discussing with the CSC what its plans were to expand to 24/7 provision, which Oxford successfully did. And that's one of the responsibilities of ISDNs, is to look to provide support the providers, put appropriate access to treatment in place. Now, who reads a CTA initially? That's a really interesting question. And Kiruba, I could answer that, but I'll let you answer that as somebody leading a service in a primary stroke centre, and explain why Brainomix or other stroke AI is so helpful in that context.
Thanks, Gary. I do work in a spoke hospital. Reading is a spoke. So it depends when the patient comes in, and also the competency of the clinicians at the front door. So if a patient comes in during the daytime, if the patient is seen by a competent stroke physician who can read a CTA, it will be read by them. But as you know, many of the patients do come in overnight, and when we are not there, weekends. And these patients are first seen by the emergency department physicians, and they do not have the right competency to read CTAs. And in this scenario, AI would be even more useful. That's one thing. The second thing is that when a large vessel occlusion stroke is suspected, and if decisions need to be made, and those decisions are always made by competent stroke clinicians, even though they are not at the front door at that time. So we would be at home, so we will have to have the access to the imaging, and that can be easily provided with the help of AI. As George has described before, the imaging is available to you wherever you are, literally at your fingertips, and you get the answer for two questions. Is there a large vessel occlusion, and how much damage has done to the brain as a result of the stroke? And you can get that information within a few minutes of the scans being done. And as I can tell you that in our hospital, if a patient presented out of hours and had a CT angio, they do not get reported until 24 hours later, because we do not have a CTA reporting radiologist overnight or most of the weekends. So so having an AI imaging tool has been really helpful. Hope I answered the question.
Yeah, thanks for that. That's a very full answer. And I'll let there's also the question about the rota again, which I'll let George answer as a stroke physician in a comprehensive stroke centre. And then also a very good question about from Linda on big increase in procedures, and how did the hub manage that in terms of capacity and scaling? So one thing I would say is the commissioning resource was there, so the money was there through the specialised commissioning payment for thrombectomy. But again, I'll let George just comment on some of the challenges that were in that scale up of provision.
Thanks, Gary. Yeah, yes, we do. So we do have an internal rota for thrombectomy in Oxford, and we have sort of absorbed it into the existing on-call stroke physician rota that existed anyway. Before thrombectomy, we provided a 24/7 thrombolysis service, and so we absorbed it into that. The neuroradiologists have also absorbed the workload into their existing rota, so they have a 24/7 availability now. But of course, you need all parts of the chain in order to provide a service. And so we've also had to create a rota with anaesthetists. So that took some time as well, because obviously, they have other service commitments in other specialties that they need to manage. But we now have a solution for that. And of course, but actually, it's not just the medical staff as well. So we have to make sure we have sufficient numbers of nurses and radiographers to support the service as well. So yes, there's a whole cadre of people that we have to manage. That comes with its own challenges, of course, because if people are working out of hours, it impacts their ability to work during working hours, and recruitment is not easy, particularly in the southeast, national pay scales and what have you. So Oxford's an expensive place to live, so there are challenges around maintaining a workforce, but I'm sure we're all familiar with that in the NHS. But what helped, I think, is that there was like all of these things, there was a clear vision and alignment at a leadership level that this was something important and that we needed to do. And so having sort of senior leadership buy-in, sort of C-suite buy-in in Oxford was really important to make sure that that we could end up delivering the services required. And beyond that, having I was going to say scrutiny, but I think input from national leadership, David and the team, and and the NHS centrally, reviewing the service provision and providing input as well, also puts a spotlight on it and enables us to justify the resources to provide the service. So it's a big lift. It's an important part of it. The network is absolutely critical, but equally, you're right, you do have to address the provision of the service in the centre too.
Thanks, George. And just to add to that, it does emphasise the importance of having a clear business case developed within the CSC to expand the service across multiple directorates, which is never easy. But there are also resource savings in the spokes, because some of these people would have been disabled occupying an acute stroke unit bed, so that frees up resource. Equally, to take these additional patients into the CSC requires some capacity there, and one of the things which is important in the pathway is to have repatriation of patients as rapidly as possible from the comprehensive stroke centre to the primary stroke centre, or the comprehensive stroke centre acute stroke unit becomes completely full and it can't manage its own patients and further referrals. The additional question around CTP. So in our network, the CTP is used routinely for acute imaging in Oxford in the CSC. It's particularly useful for those who are aware of stroke in decision making for patients presenting beyond 6 hours, where some patients are eligible for thrombectomy. It's not an expectation that CTP is used in the referring spoke primary stroke centres. We rely on CTA for that decision making of transfer, although some of the centres such as Reading are starting to use CTP, but as use beyond just eligibility for reperfusion therapies, it's helpful in diagnosing some mimics, for example, and the like. So I think all comprehensive stroke centres would use CTP these days. The rollout of CTP more widely in primary stroke centres is more gradual, and David, you might want to comment on that from the national position.
Gary and Simone, thanks for your question. So there's no doubt that CT perfusion has a role both for thrombolysis and thrombectomy, and therefore we are hoping that all acute stroke centres will have access to CTP 24 hours a day. And of course, it is vitally important that stroke clinicians on a rota in those acute stroke centres have the capabilities to interpret with the support of AI to dictate which patients might benefit from delayed presentation thrombolysis and delayed presentation thrombectomy. Remember, it's part of that national optimal stroke imaging pathway. And what we don't want is lots of patients being transferred to comprehensive stroke centres for imaging. The key to success for this intervention is the right patient getting to the comprehensive stroke centre really quickly, and not lots of patients being referred on for imaging that may not be of benefit. So there's certainly an ambition, Gary and Simone, that every acute stroke centre in this country has access to 24/7 CTP.
And I think the question is who reads the imaging. I think one thing we've learned over 30 years from introducing thrombolysis is, as a stroke specialist, you have to be able to read the imaging to make the decision. And sometimes you need the backup of a radiologist or a radiologist, but not always. George, I'll let you come on to the other question as well.
Oh, thanks, Gary. Yeah, no, I sort of pick up on that question. I think it's a really interesting point that you both make about CT perfusion, the role of CT perfusion. I think it's clearly evolved over time. I think it was enabled by the early late time window thrombectomy decision making, but actually now we don't use it at all in our decision making for thrombectomy in Oxford. It's all done on non-contrast CT, provided you have the right tools to interpret it and you can do it well. But actually, I must say I fully support the rollout in every stroke hospital of CT fusion. I think the value is I rely on it quite a lot for those objectively for those late time window thrombolysis decisions or wake up strokes, but also, as you said, that sort of diagnostic uncertainty. It's a really difficult thing to do, front door stroke medicine, as we all, or many of us on the call know, and actually having that extra information can be really helpful in identifying those patients we should be treating. Just to pick on the second question, if you want me to answer that about AI. Yeah. So how's the AI software, the output, the quality tracked? And what level of performance is acceptable, and do we track it? So really, really important question for us as a manufacturer, and it really speaks to our sort of post-marketing surveillance activity. So how do we monitor the performance of the software when it's being used in the real world? So there's a few ways that we do that. We automatically, every scan that's processed, every deployed server that's processing scans, we track and monitor in real time to make sure that it's got good uptime, that there aren't a large number of errors. So for example, lots of inappropriate scans being sent to the server, that sort of thing. So we proactively surveil the use of the technology as it's being done. But then we also work with centres to do sort of prospective validation activity to ensure that the performance is as we expect according to our regulatory claims, to make sure that we're not drifting away from what we'd expect. The false positive and false negative thing is a really important one. It's very strongly driven by the prevalence of a condition. So if you scan many, so every head CT scan that comes in, you do get increasing number of false positive alerts. And if you're more selective about who you scan, then obviously the experience of the performance will improve. There's a lot around. It's not just about the performance software. It's a lot about education and understanding the impact of how you're using the software on your decision making, that we spend quite a lot of time thinking about, to make sure that people will extract the value. It doesn't have to be perfect, but you have to understand how the software is behaving and then be able to use that understanding to extract the maximum value in your decision making.
Yeah, finally, last question, then we'll need to finish, about patient public involvement. So I think you asked about both, this is from Daniel, but asking you both about the development and the validation. So I think in terms of the validation, I personally don't see that public engagement is relevant for that. That's a technical exercise. And remember, this is being used as a decision support tool. It's not making the decision for treatment. But Tracy, do you want to make a comment on that? I mean, in other work, we are looking at patient views on things like remote robotic thrombectomy and the like. I know in our team, the patient involvement group is doing that. I think in this project, I can't recall, did we have any discussions with patient public groups about the use of AI?
Quite limited. I think that one of the things that we did discuss it at some length as to how would you do it and how would you involve them. I think the important thing is that people should be aware, and the work that we've been doing elsewhere and the research that we did and literature reviews were more around how do people respond to this and how would they respond to it. So I believe that awareness is important. You can tell people about it, and get their opinion. What do they think about it? It's part of the general AI awareness of how technologies are working, and I'm sure a lot more work needs to be done on that.
Yeah, I agree with you. I think it's a generic issue rather than a stroke-specific issue in terms of public views. But I think this is pretty non-contentious compared to some of the other stuff.
But it is a decision, just to say, it is a decision support tool.
Exactly.
Also, it's very important to remember that.
Yeah. Kiruba, do you want to make a final comment?
It's a very final comment very quickly. A patient who had stroke and also a lay member were integral part of the Titan network when we were discussing about incorporating artificial intelligence and agreeing protocols. So they were actively involved in the decision making around it when we implemented it.
Yeah, thanks very much. I think that's a really helpful point, because I think we wanted to involve patients in the kind of broader development of the network rather than specifically around this element of it. So we did have that input there. Thank you. So I'll roll on to the final slide. Top tips. I think these are familiar to anybody in the Health Innovation Network, and I'm not going to go through these. You've heard about them today. And then the final slide is to say, please give us your feedback. And just to thank all of our speakers, and we hope this was of interest and of value. Thanks very much, everybody.
Thank you.
Bye.